Okay, so let's face it. Textbooks are vital resources for learning, and they give us a roadmap for understanding diseases. But when the rubber hits the road in real life, things rarely play out the way we have been taught. So, we're going to talk about an myocardial infarction today. The perfect MI in a textbook doesn't always show up in the ER. So, today we'll explore how real life myocardial infarction cases often differ from the textbook versions, and more importantly, how we as doctors can handle these challenges in a hospital setup in real life. So, in textbooks, a classic MI presentation is a very straightforward situation. They give us a very typical presentation of a patient with sudden sharp chest pain radiating to the left arm or maybe to the jaw, and patient might be sweating, feeling nauseous, or can have an SOB. They will give us risk factors like older age, smoking, diabetes, family history. And very nicely, we know the diagnostic tool ECG, where we see an ST segment elevation or a depression, right? Along with elevated troponins. Now, textbook treatment for MI can be to administer aspirin or to give a nitroglycerine or to give an antiplatelets. Reperfusion therapies like PCIs or thrombolysis within the golden hour, and all these sound simple and well defined. But let's see how real life cases challenge these textbook scenarios. So imagine a 38-year-old man, okay, a marathon runner, doesn't have any chest pain. He just have back pain, and he comes with dizziness and some mild shortness of breath. And his ECG and troponins are normal at first. Now the textbook tells us no chest pain, no MI, right? Now this is a young healthy guy with no chest pain. So we might assume that he doesn't have an MI. But here's the real solution in real life. Even if the patient doesn't have textbook symptoms, you cannot rule out MI just based on a normal ECG and normal troponins in early hours. In these cases, we re-evaluate regularly. So monitor for any changes in symptoms or test results. You may need to repeat an ECG and troponins after a few hours, as they can sometimes be delaying in rising. So in this case, we could very well be having a silent MI or an NSTMI. And early intervention can save a life. Now, let's say you have a 60-year-old woman. She has diabetes and presents with nausea, with extreme fatigue, and some upper abdominal discomfort. There's no chest pain. She's not complaining of any chest pain. Now, the textbook says women might present atypically, but without chest pain, it's unlikely to be an MI. Mostly, right? So, this is a woman with diabetes and atypical symptoms. Now, in real life, in textbooks, it's unlikely to be an MI. But in real life, don't let the lack of chest pain fool you. Diabetes and hypertension are risk factors for MI, and presentation can be subtle. What do? Trust your clinical judgment. If the symptoms seems unusual for something like indigestion, think about other causes. Get an ECG and check troponins. Even if initial tests don't show how much you should keep the patient under monitoring her condition and escalate the testing if symptoms persist or even worsen. It's crucial to rule out MI through regular follow-ups, even when the symptoms don't match the textbook definition. Again, it depends upon the patient's age and other risk factors as well. Now, here's the big challenge: the silent MI. We see it more than textbooks often describe. A silent MI can be seen in a woman or a diabetic, and beyond just these two categories. Silent MIs in women and diabetes often present with symptoms like fatigue, nausea, vague chest discomfort, none of which scream heart attack, right? So diabetics can suffer from autonomic neuropathy. We all know that, which may mask the chest pain typically associated with MI. So, what do we do in this case? We have to be very proactive when assessing at high risk patients. Even if their symptoms don't scream MI, you have to be very careful, especially in patients who are diabetic. So, if a patient has risk factors like diabetes, hypertension, family history, and he presents with any non specific symptoms, don't dismiss it too quickly. Order an ECG, and if you're unsure, consider a stress test or a coronary angiography to rule out underlying issues. Monitor troponins over the time if patient's condition remains unclear. Now, many of you who must have been studying for USMLEs and IFOMs, you must know that we have a very nice table of patients management with angina. Is that if someone has an angina, get an ECG. If shows ST segment elevation, take them to a cath lab. If it is non-ST segment elevation, get the troponins done. If the troponins are negative, then do the stress test. Now here it will differ. We order an ECG, and if we are unsure, we consider doing a stress test. Now again, stress test depends upon the patient's condition, right? He must be eligible to do a stress test, exercise stress test or a pharmacological stress test. So the key here is that when you suspect an MI, don't let the absence of classic symptoms stop you from investigating thoroughly. Okay, now what about those cases where the test shows everything is normal but you still suspect an MI? Normal ECG, normal troponins, but it's still an MI. So, a 45-year-old man comes with a complaint of dizziness, back pain, mild SOP, and is otherwise healthy. ECG is normal, troponins are normal, and just within the normal range. So, according to the textbook, MI can be ruled out. But here's the real life solution. How do we handle it? The first test is never the final word. Remember, the first test is never the final word. Some MIs, especially those in early stages, may not show up clearly on the ECG or with the troponins at first. So, what do? Keep monitoring the patient even if initial tests seem to be negative. Repeat the tests after few hours, and the silent progression of MI can sometimes show up later on. So remain vigilant. Serial ECGs and troponin measurements are essentials in this solution, in these situations. So you have to be very careful, and then make sure that you're following up with the patient. So if some symptoms persist or even worsen, you should escalate the investigation to cardiac imaging like echoes or angiographies. This is to rule out the underlying coronary issues. Now, if the symptoms seem suspicious, even a normal ECG will not rule out MI. Now, how do we bridge the gap between what textbooks tells us and what happens in real life scenarios? So, it is very important to close the gap. How doctors deal with these situations are completely different. First of all, you have to trust your clinical judgment. Just because a case doesn't fit the textbook doesn't mean that it's not an MI. We need to look beyond the textbook and ask ourselves few questions. And how does the patient present? What is their risk profile is more important. Now, don't rely on the first test alone. ECGs, troponins, and other tests are also important, but they can be misleading. Don't forget that, especially in early stages. So repeat tests and follow-up care are crucial. So keep a close eye on any patient with risk factors. Even if their symptoms don't match the textbook, investigate thoroughly and escalate the care if needed. Early diagnosis can be life-saving. Remember that age, comorbidities, and their impact on MI is very crucial. Now, textbooks often don't adequately explain how age and comorbidities complicate an MI. Early patients might not present with classic chest pain, but uh, could have symptoms like confusion, weakness, fatigue, and these can be mistaken for something else entirely. Patients with multiple comorbidities such as diabetes, hypertension, CKDs, they will often have vague or atypical symptoms, making diagnosis more thicker. So the solution to this problem is comprehensive assessment. For these patients, don't rely on just the classical symptoms. Look for unexplained fatigue, confusion, or generalized weaknesses. For elderly patients or those with multiple comorbidities, always use comprehensive assessments. Pay extra attention to subtle signs and symptoms. Always have a low threshold for, testing these patients for MI, and make sure that you're working up and following up with these patients with repeated ECGs, and don't escalate to advanced imaging unless you think it is required. So, at the end of the day, real life MI cases can be more complex than what we have seen in textbooks. The key is to stay vigilant, follow the patient closely, and remain confident, and never dismiss an atypical symptom. Silent MI, what we do is normal initial tests, and patients with comorbidities all require us to be proactive and not reactive. By trusting our clinical instincts and using a comprehensive approach to diagnosis, we can catch these tricky cases early and provide a better care to our patients. Remember that textbooks are guide, but practice is where the real learning happens. So let's keep practicing, learning, and growing together. Thank you.